Hello, everyone. Welcome to the Medicaid Business Transformation DC Value-Based Payment Learning Collaborative. Medicaid Business Transformation DC is a technical assistance initiative funded by the DC Department of Healthcare Finance. This session is titled Clinical Documentation and Coding for Value-Based Payments and will be presented by Debbie Witham and Todd Usty. The Learning Collaborative session recordings and slide decks will be posted to the Medicaid Business Transformation DC webpage, along with additional value-based payment resources. Please feel free to add any questions for the presenters in the chat box throughout today's presentation. And here are our presenters. I'll hand it off to Debbie to introduce herself.
Hi, everybody. I am Debbie Witham. I am here in HMA's DC office, so super excited to be here with all of you today. I'm a social worker by background. Prior to coming to HMA, I worked for CARF, where I oversaw the standards development training and our relationship with SAMHSA for opioid treatment program accreditation, and then also the federal policy stuff for all accreditation areas. Before that, I was on the provider side, overseeing systems that were integrated with behavioral health, primary care, housing, and lots of other services. And a lot of that was working towards getting ready for value-based payment. So I'm super excited to be here with you all today and talk about this. And turn it over to my colleague, Todd.
Thank you very much. I am having video issues, so I am not even going to try. I'm trying right now. I don't know if you can see me or not, but I'll probably do this without video. I'm a lot older than I look in my picture, and I've been around. I'm an ER doc by trade. I've run ER groups. I've actually opened the walk-in clinics and family practices. I've done a lot in healthcare. I'm still working in emergency medicine, but I started Marcy Medical Audit Resource Services, Inc. about 32 years ago to review documentation and coding. So we started inpatient and then moved our way on to everything else, which when Medicare Advantage and risk-adjusted reimbursement came around, it's kind of DRGs all over again, but a little different. So it was right in our wheelhouse, and I've learned a lot. We've been working this for 15 years, and I am a provider's provider. I love the practice of medicine, and I'm going to tell you that this is going to be different, but I think it's actually better. So I think I'll tease you with that and leave it there.
Thank you, Todd. So there's continuing education credits for social workers, and continuing medical education credits will be available for the session. To be eligible for continuing education credits, you must participate in the full session. So you have to be here for the entire time. To request credits, please complete the online evaluation that will be shared via email after today's session. I will also be dropping the link towards the end of the session, and certificates will be emailed to participants in about 10 to 12 days. So I'm now going to turn it over to Debbie. I believe that we have a poll.
All right, so we want to know from everyone who we have with us, right? So that we can make sure that we're emphasizing the right information and just learn a little bit more about you. So Kian is going to start a poll for us. And the first one is, what type of a provider are you? Mental health, SUD, federally qualified health center, other primary care, or care management. We have it is a single choice. So if you are more than one thing, I'd say pick what's your primary. Then we want to know a little bit about where you are on the spectrum of payments, of value-based payments. So single choice, we have a contract with MCOs, yes or no? We have contracts with MCOs with quality incentives, yes or no, so that you get more payment if you meet certain quality measures, or you're entirely fee for service still. And then what we really want to know, if you could put this in the chat, please, is what is your biggest fear for the transition to value-based payment?
So we're going to give them a minute to answer. By the way, when I'm asked what provider type am I usually say pretty good.
How are we doing on the poll, Kian?
Pretty well. So should I close it? We have about 66 participation. 66%.
Yep, let's go ahead and close it, and then we can see if others can join Serafina in the chat box, because she's brave and has told us her biggest fear. All right. So it looks like we are completely even SUD and FQHCs, followed by completely even mental health and primary care, and then 11% other care management. 72% of our audience today has managed care contracts. 28% do not. 28% have with quality incentives, so the majority, 72%, do not. And about 56% bill entirely fee for service, so that's getting pretty close to even. Thank you all for sharing that. So we have a lot of great breadth of providers today. I'm going to start reading off what we're seeing in the chat. Data tracking and extraction. Opportunity for pharmacists to contribute. Data tracking. So that is a definite common fear, right, for value-based payment, because we have to be able to really pull. Oftentimes we're doing more than one thing. So pulling from multiple systems and being able to show payers the great work that we're doing, right? That is one of our biggest fears. And then also being able to have an eye ourselves on our population and the quality and outcomes that we're seeing. Opportunities for pharmacists to contribute. Yes, ensuring enough visits for cost coverage. It's a really big challenge in the beginning, is knowing your costs, right? Knowing your, understanding how much it costs to deliver one unit of service, making sure you have that information, right? So you can staff up appropriately to deliver the services that are going to bring you the revenue that's going to keep you able to continue to deliver those services. And a lot of that comes from data too, right? Because that's where we get our cost information. Opportunities for pharmacists to contribute. That can also be a strength as well, because we can oftentimes in value-based payment, we're not always just looking at the therapist or the physician or the NP in their chair delivering services. We're thinking about who makes up the care team and are able to provide some services that we didn't typically bill for.
I think also the pharmacist idea is that it does take a team to make this work. This is really all encompassing. It encompasses everything from the time a patient signs up until all the way through their care, everything we're doing for them, everything comes out of one pool. And indeed, having some ideas about maybe better ways or less expensive ways to do the same thing, etc. And some other ideas, because pharmacists are more about, my pharmacist has helped me out a number of times without, not just about the drugs. It's about some of the conditions also. So yeah, it really is going to take a team. And I think we're going to make a big point about that.
Absolutely. Absolutely. There's so many advantages that are coming and so many opportunities to deliver care the way we always wanted to deliver it. Yes, data tracking and poor collaborative efforts, making value-based possible to just difficult to accomplish, because this is a huge change, right? We used to, in fee-for-service and other payment methods, times we almost saw the rest of the community as a little bit of a competition at times, because they might take our folks. Now we have to really figure out how to partner together, but also making sure that they deliver the same quality of care that we do, so that when we send our clients, our patients to them, that they're delivering care the way we would and sending them back to us healthy, so that we continue to meet our quality incentives. That is huge. Unpredictable revenue and staffing challenges. Absolutely. We're used to the thing about fee for service, right? We're used to, regardless of how low the rates are, we're often used to at least knowing I'm going to perform the service, I'm going to bill in about 3 weeks, I'm going to have most of my revenue that I billed out. Whereas with this, it's much more about how do we kind of figure out our costs and what it takes to deliver that service, and then how do we staff appropriately for that. And we're in the middle of a workforce crisis. So how do we make sure, how do we even bring in the right staff to deliver? to deliver those services. So thank you all. Give it a few more seconds to see if anyone else wants to jump in with their big fears. Loving what I'm seeing, super honest. And you know, this is the fears across the country as well. We were on a call earlier, a listening session with providers about quality, and their biggest challenge is tracking data and making sure it's clean. All right, so I'm going to turn it over. Oh, how does that revenue equalize between similar providers for the same metric? Absolutely. How do we know that it's fair and that everyone's being measured at where they should be? So some of these things we're definitely going to be able to talk about today, at least as far as what we can predict from the things that are within our kind of control around how we document and how we code things. And how that can all lead to improving our revenue. And I want to thank you all, because it is not easy to put your fears out there in front of everyone. So thank you all for that, because this is really going to help us to think about how we structure this. And I'm going to turn it over to Todd to talk about the agenda.
Maybe I think you were the agenda.
Okay.
I go
So-
for it. Go for it.
Okay, so we're going to go to an overview of clinical documentation, and then we're going to talk about, so that's just kind of giving an overview. What should be in the documentation? And then we're going to talk about how to align the clinical documentation with our coding practices. So make sure the documentation backs up the code. We're going to talk about risk adjustment, documentation, and coding. So there we go again, right? Like, this is what's going on, the risk that the person has. How do we document and code that correctly? Medical documentation to optimize value-based reimbursement, and most importantly, enhance patient care, because this is the opportunity that value-based care brings. And then we're going to talk about quality. And then that's mostly around clinical documentation, and then also around quality measures and some of those differences about how we've historically looked at quality. And from all of that, we want you to learn and be able to, like, our learning objectives, if we've done our job well with this agenda, is to describe the importance of accurate clinical documentation and its link to coding, discuss the coding for value-based metrics, and then you'd be able to explain auditing and compliance monitoring. So what does good documentation program look like in practice? So the first thing you really have to do is develop your quality program. And so think about what you want to measure, how you're going to measure it, and then how you're going to track what everyone is doing to make sure they're doing it according to the systems that you've set in place. And then you need to develop both your documentation system. So how do you want people to document? What type of documentation do you want them to use? What do they document in an EHR? What are some of the data systems that you want to use? What do you want to be tracking? Ongoing staff education, right? That's the most important piece, because we think sometimes we train them on our documentation one time and we hope they get it, but it's an ongoing learning process. It's part of how we continue to train on evidence-based practices, how they document, continuing to look at the quality of the documentation, and then executing the program and monitoring, and always monitoring how your clinicians are documenting and how they're showing the work that they're doing and showing the quality. And next slide, Kian. So some of the things that you've often probably heard about, the golden thread of documentation, that's where we always want to keep this centered when we're talking about documentation systems, is we want to make sure that we're seeing that our documentation tells a story and that we're seeing what's happening with the person that we're serving. And that begins at assessment, right? And then we need to make sure that what we see in the assessment it leads to the goals and objectives and the interventions in the care plan or the treatment plan, right? And then we make sure that that's what drives the clinical notes, that it matches what's in the treatment plan, that the interventions we're delivering are what we put into the treatment plan. And then it goes in a circle, right? Because it's not linear. None of these are one discrete episode or a form, right? They're a process. So the clinical notes, every time we're meeting with someone, we're doing an assessment. And if that person changes, we have to update the treatment plan if their circumstances change and their symptomology changes. So we need to make sure that we're always following this and we're continually assessing, updating, and that all of our documentation follows this flow. Next slide, please. So when you're thinking about, so that sounds easy, right? We just make sure we tell a story, but it's not, because there's a lot of people who really care what's in that story. And so when you're designing your documentation practices, you need to think about who are those most important stakeholders, and you need to align them. So you think about your regulators. So if you are an FQHC, you think about what the Department of Health wants to see, and you're thinking about what HRSA wants to see. If you are an SUD provider, you're thinking about what DBH wants to see, about what DHCF wants to see. If you're accredited, you're thinking about what the Joint Commission wants to see, what CARF wants to see, what Council on Accreditation wants to see. As we move into managed care, for those of you that are already in managed care, for those of you that are moving into managed care, we're thinking about what does that MCO want to see, and what are they going to pay me for when they see it? And then we're also thinking about the clinicians, right? Because we have to think about designing a documentation system in a way that works for them and doesn't create more administrative burden, and allows them to effectively tell the story. And it's important to design the system to really align, look at what all of those people are asking for, find the commonalities, and design the system so that we're doing that and within one node, and then crosswalking their regulations, contract terms, and developing the documentation practices through that. Next slide, please, Kian. And so when we think about the treatment plan, we need to make sure that it's based on the assessment and the diagnosis, right? So we need to see that everything that person talked to us about throughout our assessment process and whatever diagnosis that led to, that's what's driving the treatment plan. So if we say the person has an opioid use disorder severe, we need to make sure that we're designing the interventions and that's the level, first off, that the assessment supports that diagnosis, right? But then we also need to make sure that the level of services and the frequency meets the what would be best practice for that diagnosis. And we also need to make sure that the diagnosis, and this is medical and behavioral health, is updated in real time as information changes. Sometimes when we meet a person, we may not have a full picture, so we may give them a diagnosis of something unspecified, right, or rule out. So we need to make sure that we update that as those things change, so that the interventions that we're making, that we're delivering, match the diagnosis. And we always need to make sure, again, medical and behavioral health, that those interventions and that treatment plan is person-centered, that it's based on what that individual's goals are for themselves. We need to make sure that the clinical notes reflect the goals and objectives of the interventions in the treatment plan, the level of care and the frequency of the services they recommend. So this goes to always making sure things are updated, right? Because if we've updated the diagnosis, but we never say, you know what, this person needs to come every day for a group and they need to do individual twice a week, but we're still delivering, we never write that into the treatment plan, it's not matching, right? And so we always need to make sure that that the frequency of the level of care reflects what we say we're going to do in the treatment plan, and that we document in the system if it deviates, right? So if we say the person had a crisis, so we saw them an extra time today, or they're out of town, so they didn't come for their services, they had a death in the family, and so they did not come for their services. The clinical notes need to reflect the delivery of evidence-based practices, and these be normed for that person's diagnosis, right? We can't say if someone's been coming to see us with a substance use disorder and they are in an active phase of treatment, that we're still really that the only evidence-based practice that we're using is motivational interviewing, right? We need to make sure that we're putting in additional evidence-based practices that are for where that person is in their point of treatment. And then the notes need to reflect that you're delivering the care with fidelity to the model, right? So we can't just say we use CBT and then we go on to talk about the person's housing situation, right? We need to show that the interventions that we're using, that they're reflective of cognitive CBT interventions. We're using thought records. We're working on changing stopping techniques. And then the assessment should clearly support and document everything that's happening in the treatment plan and in the clinical notes. So this is just kind of a cross golden thread, but it goes into a little bit more detail. Next slide, Kian. So when we think about treatment planning and we think about what our payers want to see when we're moving into value-based payment, we really want to be able to show clearly what's a goal, what's an objective, and what's an intervention. And I think we often think it sounds simple, but a lot of times then we go back and we look at it and we're like, that's not really a goal, or that's not really in the words of the person served, or it's not, that objective isn't specific enough. So, and then a lot of times we'll see when we're looking at charts, we'll see interventions that are actually written as what the person served is going to do, as opposed to the interventions that will be delivered to help address the diagnosis, right? So how I often think of this, when I think of goals, I think of G, it's global. This is your bigger picture thing. This is what you want to see kind of at the end game. And it needs to be pulled, I'm going to keep saying this, it needs to be pulled from the areas identified as needs in the assessment. It can't just be this person has a substance use disorder, so their goal has to be abstinence, right? It has to be, these are the things that are reflected in their assessment, and the goals need to reflect that, needs to reflect what the person wants from the services. And then we start to get more specific with the objectives, right? That's where we start to say, this is what we're going to see by a certain time period. So we're going to see that Debbie has shown reduced symptomology of depression by October 21st, right? And then interventions, what you as the provider will do to help the person reach each objective. So it should be the interventions help you. I often, when I think about a treatment plan, in some ways, I start looking at it backwards and I think about it as steps. So the intervention is what's going to lead to the objectives, to achieving the objective. So we're going to meet with the person individually twice per week, and we're going to deliver services using CBT. And then that's going to help us get to that objective of reducing the symptomology, right? And the goal, the end goal of, I'm going to be able to stop, I'm going to feel better now. I'm not going to feel depressed anymore. That might be the person's goal in their words. Next slide, Kian. So now we're going to go through a little story, because it's always this is where this all comes alive, is when we're thinking about this and how it affects the people that we serve. So I want you to meet Stan. Stan is a 51-year-old male. He resides in DC. He has a 13-year history of heroin use and a 3-year history of crack cocaine use. He uses daily, both through smoking and injection, about 3 bottles of heroin and crack cocaine when he feels he needs to wake up. And he reports 5 prior treatment episodes. And the last time he used was just before coming to see you. And so a little bit more about Stan and his background. He does not have a professional trade or skill, and he's worked sporadically kind of under the table. And then he supplements his income, and he doesn't want to tell you too much about that because he's worried he's going to get in trouble, because there's a lot of times things that are not considered to be legal. Right now, his primary source of income is disability for pain and mobility challenges related to a gunshot wound he had sustained a few years prior. He has a limited relationship with his family, as they don't approve of his lifestyle. He does not have a current significant other, and he has 2 children, and they are aged 35 and 33, and he's had no contact with them for 5 years. He is currently unhoused, and he spends much of his time sleeping on other people's couches, and most of those people are using substances with him. And he has significant pain in his leg as a result of a gunshot wound 10 years prior, and many days he finds it painful to walk. So those are all important things that we need to know about Stan, right? Because those are the things that we need to know about how we're going to deliver services to him and what is going to impact his ability to engage and what he's going to want to work on. So let's go learn a little bit more about Stan and what he wants from treatment on the next page. Slide, please. So we want to take these goals and we want to make them in Stan's words, right? We don't want to say, you have to stop using. We want to say, what do you want out of this? And he says he needs to stop using. He knows he's going to die if he stays out there. He's seeing a lot of his friends pass away from overdoses. And he doesn't want, I don't want to die without seeing my kids again. That's his biggest motivator, right? Is to stay alive, to get to reconnect with his children. So that's what we need to include on there. So he wants to stop using all drugs so he can be there for his kids. And we're projecting that out 6 months because that was the rule on the treatment planning. And so his objective is he'll be stabilized. Stan came, the treatment center that Stan goes to is an opioid treatment program. So the first objective is he's going to be stabilized on a maintenance dose, and we're going to see evidence of that. We're going to know that because there's going to be objective and subjective reduced cravings for opioids. And we're hoping that happens within a few weeks of his coming in to the program by 12/1. The intervention for that is the doctor will meet with Stan daily for the first 2 weeks to adjust his dose until it's effective at suppressing abstinence symptoms. And then the next objective is he's going to increase his understanding of his substance use by identifying 3 triggers that could result in use of substances. So this is where we start to think about, okay, what are some of those behavioral, what are some of the tools we're going to need to stop to reduce our use? And what are the interventions for that? So remember, this is worded from the phrase of the counselor. So he's going to meet with Stan weekly and utilize motivational interviewing and cognitive behavioral therapy to identify situations that could prompt Stan to use substances, right? So there we're talking, the intervention is the therapy and the evidence-based practices that we're delivering. You can, next slide, Kian, please. So now thinking about documenting that in the note, this is based on the DBH treatment note format. So you want to look at the focus of the session. So in this instance, Stan, so a little background of what's happening with Stan before this session is he lost his housing on the place that he was staying because the other folks were using, and he's having to go into a shelter, and he wants to leave the shelter and go back to the house where everyone else was using with him. And so this was a session that was really mostly focused on not necessarily those treatment goals that you saw, but how this impacts, but some new situations in his life and how we document that. So the session focused on his recent loss of housing and his frustration with the process of securing housing through the shelter system. So the presenting problem then is that he currently has no permanent housing. His housing resources are actively using, and they're triggers in his progress towards recovery, which is what he still wants to maintain his recovery. He's proud of the progress that he's made. And he feels frustrated by the process of locating housing through the shelter system and residing in a communal environment with so many people. And so the interventions used, so Stan comes in basically saying, I'm going to leave the shelter. And so the counselor delivers motivational interviewing to explore how that's going to shift him off the path of his goals. And so we're documenting that and how that could impact his recovery process. And then we talk about his response. So initially he was determined to leave the shelter, but once he engaged with the counselor and developed a plan to manage the frustration, he responded to the intervention. Next, so we always want to make sure we're showing the intervention that we used and then how that intervention caused the response. Next, slide, please. And then we talk about his goals. He submitted toxicology tests consistent with the expected results for 2 consecutive tests. He's taken steps to change his living environment, which in turn reduces his relapse triggers. He's not yet ready to reach out to his children. He'd like to feel more confident in his recovery before he reaches out to them. So even though this session was about the housing, we're still focused on the goals. And then we put in here in the italics, as his situations change, they discuss updating his treatment plan. And they added a goal related to housing because he would like to focus on, and in his own words, getting out of the shelter and into his own place and building recovery skills that help him to manage the challenging situations he faces. And then we plan for the future session, right? So they're going to meet on Friday. Stan has homework. He has to provide an update on the use of skills and tools outlined as relapse prevention plan specific to managing the challenges of the shelter system. And then we're updating the frequency of the sessions based on his needs, right? But we're documenting that, and he will reassess his weekly counseling schedule the following week and increase sessions if needed. So that's what we want to make sure we're showing when we update the treatment plan based on this new significant event in his life, that we're saying this is why we're adding that extra. He's in a place in his recovery where he's more at risk of returning to use. So we need to increase the dose of what we're providing, right? So next slide, please. And I am going to turn this over to Todd because he does a great job of giving very quick tips on documentation.
Thank you very much. And Debbie, I need to thank you for those last slides. It's a little known, but I do have sort of a side job where we have a group that are underneath a fairly conservative Florida sheriff in our county. He is providing opioid use disorder treatment with buprenorphine to jail inmates, and we follow them up afterwards. And while you were doing that, I realized we're not doing all of that in our follow-ups. So we need to do more in our follow-ups. And so thank you. I learned something. So a couple of tips. So I know that what Debbie just did was there's probably more documentation in mental health and substance use disorder than there is in medical, although there should be some very important things in medical. So first tip is a condition only exists when it's documented. So we know, I always call my patient Joe. We know what Joe's had for the last 3 years, but if we don't document it this year, it doesn't count. So diagnoses not carry over year to year. They can carry over visit to visit. So do you have to have that a diagnosis of COPD in every visit this year? And the answer is no, although it's probably good form to say what you evaluated and you assessed. And I'll get into some of how you do that. A condition can be coded and reported as many times as a patient receives care and treatment for the condition. It's only going to make it, so this is risk-adjusted reimbursement, risk adjustment. It's different than fee-for-service, and it's really based on these diagnoses. It will only count once, okay? But we should code it every single time we see it. We should document it and code it every time they see it. And we let the payers and Medicaid and the big computer in the sky figure out that that's already been submitted. Conditions can be coded when documentation states the condition is being monitored and treated by a specialist. Now, here's where we start crossing a border, because in primary care, we frequently, we do a lot of chart reviews in Marcy, and we'll see in a primary care note that there was a consult with a cardiologist, and the cardiologist has 5 diagnoses. They don't care about getting all the diagnoses on the chart. If you want to know, you need to read their consult. What they've done is put 1 or 2 final diagnoses in a good evaluation, but they've only placed 1 or 2, which is not true. So it is okay to say, well, Joe is diagnosed from a cardiologist with the following. He is and list what they came up with, the different specific diagnoses, and he is being followed and treated by Dr. Smith, for the cardiologist for that. That's fine. The other place where this comes true, especially in this presentation, is what if you're a mental health related person and you see that the patient has diabetes? You know, this is complex enough, and we've watched so many diagnoses fall through the cracks in the floor. Is it okay for a psychiatrist, psychologist to put in that the patient has diabetes, DM type 2, and that because you saw that in their chart somewhere? Yes, it's okay to do that. You're not treating it, so you're under the care of so-and-so. That does count. And it's interesting because the other doctor, Dr. Jones, might not have actually put it in their diagnostic statement. We find that a lot. So that the patient's being treated and nobody's getting credit for it. And by the way, vice versa. When I'm training the primary care docs, that I have a lot of primary care docs that don't want to touch mental health disorders or try to figure it out. They want somebody else to do it. But I'm sorry, it's still your patient. So when you get the results back from the mental health consultation, and you know that there's, major depression, severe, you need to put that in. So, and under the care of, so I think the medical legal part of this, people shy away from talking about anything that they're not quote unquote trained to do. Well, nobody's saying that you have to be the one doing it. We're just saying that it needs to be recorded and somebody else can actually be doing it. Please don't code diagnoses with less than, I put 95% certainty. For those of us that do primary care, a lot of times we're not entirely certain that we've got the right diagnosis, and it might be after we treat them for 6 months and it all got better or went away or got worse and whatever, but it confirmed our suspicions. I think, it could be 90% certainty, but if you're trying to figure out if you still have a differential diagnosis and you're not sure, we don't put that down as a final diagnosis yet. You can't use possible or probable or likely. You can, but it actually cannot be submitted as a code, even though because that's what you're still evaluating. Interestingly, in inpatient, you can do that. So any of you that have worked inpatient might know that possible, probable, likely actually codes as if it is. But in outpatient, they figure that you're going to keep bringing them back. You don't keep bringing them back as an inpatient. You're going to keep bringing them back in the outpatient setting to figure out, well, which one is it likely to be? And is it most likely? Which one am I hanging my hat on in my treatment plan, etc.? Coexisting conditions can be coded when documentation states that the condition affects the care, treatment, or management of the patient. So, by the way, conditions, I should probably point out that symptoms are not conditions. Signs and symptoms are not conditions. So if somebody says, I get headaches, that's not really codable. I mean, yeah, you can code it, but it doesn't go anywhere. If you're considering are these migraine, are these, muscle tension, etc., and then you come up with a final or mixed, and you come up with a final diagnosis, that's when you put it in as the final diagnosis in your treatment plan for them. Document and code status conditions at least once a year. What are status conditions? Well, the transplant status. How about amputation status? How about ostomies, chemotherapy? So some of those things don't change from year to year. The amputation doesn't grow back. Generally the ostomy is still there, although sometimes they do close them up. Chemotherapy may change. Transplant status, they probably still have a transplant. So why do you have to document and code them at least once a year? Well, this is when I tell you that on January 1st, CMS, in its infinite wisdom, cures all diseases, all amputations grow back, and all ostomies close. They don't have a diagnosis on January 1st, even though it's the same patient that had diagnoses on December 31st. Why do they do that? It's because they want one good evaluation but on each patient that they're paying for, that the government is paying for. So, actually, that's a little bit of built-in quality. I mean, it is what we should be doing, and they actually kind of force that by saying you've got to see everybody at least once a year. I actually think it should be once, in the first 6 months and a second time in the second 6 months, but that's my own opinion. Do not code unconfirmed diagnoses. I already said that. Do not use symbols like a greater than sign, a less than sign, an arrow sign. We can't code from that. And be sure diagnosis codes are consistent with medical record documentation, as Debbie pointed out. There needs to be an example of an assessment, a plan, documentation of all that. And you cannot just list an ICD-10 code. I said that about COPD. Even if you know the code for COPD, you can't just list it. There has to be more, and I'm going to get into that in a second. Can we do next slide, please? All right, and then so I'm going to hit it up. So CDPS, that is originated in San Diego. It's used by quite a few Medicaid managed care organizations, and it is the payment methodology for the District of Columbia. Medicaid risk adjustment identifies the demographics of an enrollee. So, their age, their gender, etc., comes into play, but the vast majority of revenue comes from values of risk score calculations that are based on the current year's diagnoses. And the current year's diagnosis, 2023 diagnoses, is affecting 2023 reimbursement and final reimbursement. It also helps predict what the beginning of 2024's reimbursement is going to look like. So it's all about a risk score calculation. Can I have next slide, please? So the CDPS uses a crosswalk that assigns certain diagnosis codes to an HCC. What's an HCC? It's a hierarchical condition category. I've said that so many times, I don't stumble. Hierarchical condition category. So what is that? So it's a payment model where certain conditions that are within different groups or categories, some of those conditions don't have any weight to them at all. I kind of mentioned, the stuffy nose. So, but some of them that have chronic sinusitis, bacterial sinusitis, etc., that's more specific, it has some weight to it. So you will not know whether it has enough weight or not. It's just what we're asking is, what is the diagnosis? It will be put into a category group. So you've got a condition in a category group. And if it is weighted, how heavily weighted is it? Well, that's already been figured out. We don't have to figure out any of that stuff. And I would implore upon you not to try to game the system by, I'm only going to use the heavy ones. No, because if the patient doesn't have it, there's an F word, FRAUD, that goes along with just trying to game the system. You don't need to. This works totally without it. So hierarchical condition categories. Next, please. So what is risk-adjusted payment? So I wanted to make sure that we walk backwards to value-based reimbursement, and how that actually works. So it's risk-adjusted. It's a value-based reimbursement methodology. The documentation requirements are different than fee-for-service, and this is not fee-for-service. As I said, the majority of the revenue that comes in to take care of patients under, well, this will be Medicaid in DC, the majority of the revenue comes from the diagnoses, not from the traditional, what type of office visit did we do? What were the procedures that were done? No, this is all about diagnoses. So ICD-10 coding translates into HCCs, then that have more or less impact. So those are the hierarchies. HCC codes are weighted and result in risk scores. So there's actually a thing called a risk adjustment factor. I will tell you that they normalize the risk adjustment factor based on all of the data that they get from all over anywhere that is using their model, in the CDPS model. So they're looking at, so what is the average patient's weight as far as a risk score? So, if you come in less than that, then that means your patients are probably more well. And if you come in bigger than that, your patients are more sick. Either that, or if you come in less than the average, you just didn't list it all. And therefore, there's less money coming in to take care of those people. So the weights, the RAF translates into the revenue. All the revenue is pooled for the patients in a plan. So, and for Medicaid, it's going to pool all this, and all expenses come out of that pool. All expenses. It's not just what they pay the providers, but it's the lab and the x-ray and the consults. Oh, and the big ones are the hospitalizations come out of that pool also. So the sickness, the illness burden of a population should be reflected in the risk adjustment factor. And that's going to include a certain amount of hospitalizations. It's going to include costs. And they do normalize that. So we need to make sure that we are capturing everything that the patients have, whether it risk adjusts or not, because again, you will not memorize everything that risk adjusts, nor should you. Next slide, please. So here's the goal. So the goal is actually kind of cool. I love the practice of medicine, and this this reimbursement model incentivizes us to identify all the patient's disease states each year, and document them per guidelines and code them specifically, and basically capture all the defensible revenue. So the focus is on patient care, is on finding their disease states. By the way, there are quality measures that pay for preventative care, which are, they don't have disease states associated with them. So they built in quality to keep people well, but they also have built in quality for taking quality care of people with their problems. So you need to address their conditions whenever it's needed. Yes, you need to try, if somebody's sick today, if they're having crushing chest pain, they go to the ER. Got it. I'm an EMS guy, ER guy. But if they just don't feel well, can we work them in? And can we see them? Because I'm an ER doc. If you say, you don't feel well, go to the emergency department. I've done so many emergency department reviews of Medicaid patients that were told to go to the ER, and they spend thousands of dollars on people with minimal problems, and you're just draining the pool. If you can see them or have space or make space available, it sure helps. So take care of conditions when they need to. Take really good care of our patients. Try to reduce hospital admissions and readmissions. When they get discharged, we should be seeing them in the next 36 hours. We should know that they're being discharged so that we can follow up with them, especially in medical cases. Joe got admitted for a COPD and his CHF, his chronic diastolic that became acute, and they tuned them up. They sent him home. But he's never been admitted for his CHF before, and he doesn't quite understand what to look for, and he's not feeling quite right. So where does he go? He goes back to the ER, and they readmit him. There's a lot of wasted money there. There's a lot of wasted readmissions. So find all the diseases, take really good care of them, try to keep them out of the hospital. Oh my gosh, that's what I went to medical school for. I mean, literally, it's a reimbursement model that parallels the practice of medicine and creates quality as a natural byproduct. So the focus also creates a revenue surplus. Oh, so this is about dollars also, and there should be enough money to take care of everybody. As you all in the Medicaid system matures, just like the Medicare Advantage system has matured over the years, the doctors went from, now you can get paid that way. You're the payer. You can get paid that way, but I want fee for service. Whilst now over half of all Medicare Advantage is over half of Medicare is Medicare Advantage. The payers now control over half of the patient lives. So they're going to the providers saying, we want you to take some risk too. We want you to find all the diseases and take good care of them and keep their butts out of the hospital. And if you do and there's surplus, we'll split some of that surplus with you. If you don't, and we have to pay back because we spent too much, it comes out of the providers. That's called a full risk contract. They do have limited risk contracts also, and I'm not going to get into all that, but it's kind of, all you have to do is do the right thing, and there's usually a surplus left over if you have enough covered lives. Can I have the next slide, please? So really the challenge is to improve risk score accuracy. We want everything that gets coded to be defensible. Marcy has prided itself for 32 years on not just finding undercodes, money that could have been made. We also tell our clients, wait a minute, you coded this and the patient does not look like they have that. You coded too far. So it's really, the challenge is related to physician documentation, and I should say provider. Most of the people in my group are PAs and nurse practitioners, have a couple of doctors. So there's a trap, and that's focusing on finding things to code. Do not look for things to code. What you don't target certain codes and certain diseases. What you do is we're emphasizing the accuracy. Just find their conditions and be as specific as possible about those conditions. So, and just get more and more specific as to what they have. transition our mindset away from the fee-for-service volume-based model and think about it. This is about value-based reimbursement. It's about quality care. So find all the diseases and conditions and be as specific as possible. Next slide, please. So how do you optimize reimbursement? And that really should say optimize defensible reimbursement, because we don't want to be paying money back. Nobody does. We don't want to get charged with consistent overcoding. But you know, if you just do the right thing and don't try to do that. By the way, there are certain spots that we have audited recently that have been they've worked on this so hard that they are consistently overcoding, and they are likely to be in trouble soon. Next slide, please. So let me do a little bit about psychiatric. There are not a lot of psychiatric codes in value-based reimbursement. So you have psych low, PYSL, the L being low, medium, there's an M, and high, there's an H, substance very low, and substance low. There's no substance medium or high. That's like weird. But everything changes. So everything I'm telling you now could be different next year. At least they won't change everything, but they'll change some of it. So if a patient has depression, and it's only depression is what is documented. Patient has depression, yeah, but that just codes as depression. It does not risk adjust. So you're treating a patient with depression and nobody's getting paid for that. I mean, you're getting paid your capitated rate or whatever, but there's no money coming in to cover our work. So what we want to do is know, is it a major depressive disorder? I mean, major depressive disorders risk adjust in all models. And if so, could you say, is it a single or recurrent? Because that helps us code the right one. Is the severity, is it mild, moderate, or severe? That helps us code the right one. And is it partial remission or full remission? And it's okay, you can still code it, and it still gets paid for when it's in remission because you're doing a good job treating it. So partial remission would be you're still treating it. Schizophrenia versus eating disorders versus bipolar and major depressive disorders. So schizophrenia is in the psychiatric high, eating disorders are in the medium, and bipolar and major depressive disorders are in low. So I'm not sure if that fits with your construct, because I think some of those are in the wrong one, but that's what you get. That's what we're dealing with. Next slide, please. So no matter whether it's psych, substance, or medical, there's the auditors are looking for a few things. Okay, they know that they're asking the providers to accurately document the diagnoses for each visit. And they want us to do the government didn't come up with this with the MEAT, which really should be MMEAT. It's an outside group came up with it, but it's been pretty well adopted across the country because it makes so much sense. So M's are managed or monitored, needs to be documented. How and who is monitoring and managing the condition. E for evaluation, that could be from DSM-5, or it could be from your examination in your history with the patient, because history is so important. A is for assessment. What is the assessment that day? What was the assessment in total? And what is the assessment that day? Improving, worsening, progressing. And T is for treatment and or plan. So you, again, if you just write down a drug, that is not a treatment and or plan. You have to put in, so when these things get submitted to Medicare or Medicaid or to the commercial carriers that are doing a lot of this, it's going to go through, it's going to be on the books, and they go back and they audit. So the government audits a lot, and Medicaid will get audited, and they will look and go, well, they put down, depression, but they coded major depression severe, but it doesn't say anything about that. We want our money back because depression doesn't pay, major depression severe does. So that's what happens after the fact. So if you can remember the acronym of MMEAT, managed, monitored, evaluation, assessment, treatment, or plan. You don't have to have them all. It's nice because, quite frankly, you're doing it all. So it's nice. It's a nice clean note. At least once a year, you should probably have all of that documented. And then if you see them again, no, you've already, now you're doing the update. Next slide, please. So just some common conditions, psychiatric categories. Psych high, really there's only two, schizophrenia and schizoaffective disorder. Psych medium is psychosis, not otherwise specified. Eating disorders, personality disorders. Psychiatric low, major depression, single, mild, moderate, severe, on remission and partial remission. Psychiatric and mood disorders and ADHD are in the low. Next slide, please. And if you all know, see, I just went through it really fast because don't go back. I don't want them to see it again. I want you to be specific about what they have. And then when you look it up, you won't know whether it falls into high, medium, or low. And it shouldn't make a difference. It shouldn't change our diagnosis. So for CDPS, there are two categories. So there's substance use very low, and substance abuse low. So basically, nicotine dependence is in the substance abuse low. Other examples are disorders, use, abuse, dependence, opioid, cannabis, cocaine, sedative, hypnotic. And then there's substance abuse very low, which is only alcohol disorders are very low. Next slide. How are we doing on time? Should I ask that?
We're doing well.
Okay, good. So for those of you, so I work with our FQHC. We have a number of them in my county. Obviously, since we do substance use disorder, buprenorphine MAT treatment, we're actually hooked up in the health department with our FQHC and a nonprofit organization that has peer support specialists, helps with housing, we got grant money, all that stuff. So all those things happen. The FQHC is doing this dual role because they're sort of in between the substance side, that they have their own psychiatrist and psychiatric nurse practitioner, but they're also obviously doing primary care. So the FQHCs, I know that there are some out there on this talk. So you're doing kind of all this. You need to know some of the other CDPS categories, which is the same, by the way, is these categories are pretty much the same as for Medicare Advantage, except that one in the lower right corner, pregnancy and newborn conditions, because there are not a lot of 65-plus-year-olds that have pregnancy and newborns. But the other ones kind of work. So there's gastrointestinal, central nervous, skeletal, developmental, eye conditions, metabolic, skin, cerebrovascular. So those are the condition categories I was talking about. And within there, certain conditions have higher reimbursement. It's a hierarchy. These are the hierarchical condition categories. Next slide, please. So just an example. So you've got a 21-year-old female with hypertension and schizophrenia. You know she has hypertension because you read it on her chart when she was sent to you, and she is on some medication for her hypertension, and call it a Pril, lisinopril. Should you document that as a diagnosis? The answer is yeah, you know it. Does it affect your evaluation? And by the way, let's say that you are not associated with an FQHC, you are working in your mental health clinic, and can you document it? Say, yeah, but they're treating that at the FQHC. So you can put hypertension treated if whatever the name of the FQHC is. And then schizophrenia. And there are specific codes that go with those. If you notice that schizophrenia increases the risk score by a 0.271. So most, and the hypertension increases by 0.062. So the schizophrenia is what? a little bit more than 4 times more heavily weighted than the hypertension. Can you see that? So, and then there's a base amount. So there's a little bit of the revenue comes in just from the demographics. So a female 15 to 24 has a 0.036. And when you add all those up, that's the risk score. So in that multiplied by whatever multiplier there will be in DC, is that determines the revenue that comes in for that patient. That doesn't come to you. That goes into the pool that pays for all patients. Next slide, please. So now we have a 50-year-old female with hypertension and CHF. And so we have, and schizophrenia. So the hypertensive heart disease with CHF is the way to say that. That has its own code, and it has a RAF score of 0.735. Remember, schizophrenia is 0.271. You add those up, and the age factor for somebody a little bit older, that the demographic goes up. This patient has a 1.074. So I'm not sure how they're going to run it in DC, but I can tell you in Medicare Advantage, every year they equalize to 1.0 is the normal. So this patient is getting a little more reimbursement than the normal patient. If this were Medicare Advantage, I'm not sure how they're going to run that in DC. Example 3, 50-year-old female with hypertension, CHF. Oh, chronic kidney disease and schizophrenia. And I won't go through the whole thing, but be specific about each one. CKD unspecified, schizophrenia, hypertensive heart disease, CHF, and CKD. Oh, there's actually a separate code. You see that as I11.0 for hypertensive heart disease with CHF. Hypertensive heart disease with CHF and CKD is an I13, which pays 0.735, just like the other one. But it also pays for, you put in the CKD also. So, and you actually get paid for that. That's 0.928 and the 0.271 for the schizophrenia and the age 45 to 64 female, still the 0.068. That's a 2. So they're getting twice as much revenue for that patient that has twice as many problems, actually 3 times as many problems. And that, again, that happens in the background. All we have to do is be specific about their conditions. And just because you picked a condition that says and CKD doesn't mean that you also don't code the CKD separately, okay? Quite frankly, in example 2, it would have been correct to have diagnosed and coded hypertension separately, along with hypertensive heart disease with CHF. They just won't take the hypertension by itself. So they have some codes and guidelines. Next slide, please. So diabetes. I'm not going to go long into diabetes, but most of our diabetes codes are fraught with error because there are so many things. What you need to do, in the real take-home message, is that if a patient has diabetes and there's a complication, the complication needs to be linked by using words like with or due to or secondary to, showing a cause and effect relationship, because that creates a code for the diabetes with CKD, but you also pull in the CKD separately. So pulling the diabetes with complication code is not enough, but the DM and the complication need individual documentation because they fall into 2 different categories. So it sounds like you're double dipping, but that's just part of the big computer in the sky. It's not ours to wonder whether that's fair or unfair. Trust me, they're normalizing this to what is the average every year, and they want us to do it this way. Just do it this way. So it's the diabetes and the complication code. So individually documented. Next slide. And boy, this is too busy, but I will, just to kind of put you in, there's 4 cardiovascular categories, and what falls under where. Diabetes has 2 categories, type 1 diabetes, type 2 diabetes, and then there's complications. If a patient has diabetes with CKD, so it's interesting, is type 2 diabetes pays the same whether they have complications or not, but the complication also pays separately. So we need to be as correct as possible. Next slide, please. And I think this is the last one. So this is Joe. You know, we put chronic obstructive asthma with acute exacerbation. That's what we meant to say. What we said was COPD. So it's really chronic obstructive asthma with acute exacerbation. It's that code. And sorry, but we need to think more specifically. If we say heart failure or hypertension is really hypertensive heart disease. And yes, I just saw in the note popped up our risk adjustment factors that they're already populated for this year. They're using all of these diagnoses have a factor. You don't have to look the factor up. You don't have to know the factor. It automatically populates when that diagnosis comes in over there, when we submit it out of our offices, and it goes into their big computer in the sky, it will assign the correct risk adjustment score for that. So, and they're already done. They will change them some next year. They will change them some the year after that. We're not going to keep track of that. I mean, if we're going to just put down what their diagnoses are. Lung cancer, liver cancer, really what we meant to say was lung cancer with metastases to liver, which is a different diagnosis, and it pays very differently than either lung cancer or liver cancer. They're only going to pay for one of lung cancer or liver cancer, and lung cancer with metastases to liver pays a lot more. Obviously, they're a lot more sick. So alcohol abuse is not the same as alcohol dependence. History of CVA hemiplegia. So it doesn't really fly. It seems like it should, right? But history of CVA, do they still have history of, if it's gone away, some people have had strokes and history of stroke 10 years ago, and they're all better. If what you really meant to say was they have dominant side hemiplegia due to CVA, they still have hemiplegia. By the way, I didn't mention hard enough that history of doesn't get you anywhere. We see that a lot, like with prostate cancers, with breast cancer that's no longer being treated. Breast cancer being treated with tamoxifen for 5 years is still breast cancer. But breast cancer where they've stopped treating the breast cancer and they haven't for 2 or 3 years, it's a history of, and actually it doesn't risk adjust. So next slide. Quality encoding. Is that you, Debbie?
That's me.
There you go.
All right. So there's a lot of different levels of quality when we think about it, as far as coding and just documentation and appropriate payment. And I think historically, we in the healthcare field have more always thought about compliance, right? Which is really important. But that's not necessarily quality. And so we're going to kind of go through a little bit quickly here, the different types of quality systems, and they're all important and they all need to be in place in order to survive in a value-based payment world. So compliance is meeting the requirements. It's your floor, right? It's like you're making sure that you meet the requirements of your payers, of whoever's funding you, all of your regulators, DBH, DHCF especially, right? All of those folks, contracts that we have, and then also really accreditation entities. So that's compliance is making sure the note is written before we bill. It's making sure the treatment plan is signed on the date that it's supposed to be signed. So it's making sure all of those basic kind of bare minimums are in place. Reimbursement accuracy is making sure that we're billing for the appropriate service at the highest appropriate reimbursable rate. So that we're not undercoding, right? Because that's quality. If we don't get paid for what it costs us, a lot of this really also goes to knowing your costs, right? And knowing and that concern about that fear we have about are we going to be reimbursed appropriately, making sure that we're coding it to what that person's diagnosis and the service really is, to make sure that we get reimbursed at the level that we need to provide the right level of care. And then making sure that the documentation supports that, right? So that the assessment shows that that's the accurate diagnosis, and the notes show, medical or behavioral health, that we're delivering the care according to the diagnosis and the code that we put in. And then we have quality. And that is really, how are we doing at what we're doing, right? It's looking at it's looking at our outcomes. It's providing care that's evidence-based. It's looking at equity. Are we getting people in? Are we providing good access to care? And it's measuring ourselves and looking at how we're doing at what we're doing. And so I often say, when we think about a quality review, especially when this comes to documentation, you have to do all three of these. You have to do compliance. You have to make sure that the assessment was completed on time, that the code is in there, that the treatment plan was signed on time, because that's just going to keep your doors open, right? Basically. Then you also have to do reimbursement accuracy, because you need to go back and you need to make sure that you are coded, that you're not overcoding. You're not saying this person's much sicker than they are and getting more money for it, like Todd talked about. We have to make sure, but also we have to make sure that we're getting paid and that our documentation matches that. And so we need to add that process in to our quality reviews as well. And then, especially for value-based payment, we're getting paid for how we're doing. We're not getting paid for how many people come in and sit in our chairs in our medical offices, or sit in groups in our group rooms, or sit in our rooms receiving therapy. We're getting paid for how we're making them better. So we need to start looking at our outcomes, right? We need to select some measures that show how we're doing what we're doing, that we did what we're doing well. That could be reduced use. It could be reduced symptomology. It could be time in the community, right? It could be time in employment. It could be reduced negative aspects of diabetes, right? So all of those things that show how we're doing what we're doing, and then measuring them. And then also quality reviews, making sure that not just the treatment plan is signed on and is timely, but that it matches the assessment, that it matches and the notes document what's happening in the treatment plan, and that they're up to date, right? Like it's telling, we think back to Stan or Joe, and make sure that it's telling their story and it's accurate to where that person is at that point in time. And so really, to survive in value-based payment, we really need to have all three of these quality components in place. Next slide, please. All right. But that doesn't come easy, right? So some of the things that we can do to really make sure that our documentation is timely, because especially when this documentation is often how we get paid, right? And so one of those is setting a time frame for completion of notes. So it's really important in our clinical operations to let people know you need to have your notes completed by this time. If they need to be signed or locked by a higher level clinician or physician, then the time frame that needs to happen. 48 hours is something that we kind of suggest that's one option. Some folks have 24, some have same business day, but setting that time frame that's reasonable for your clinicians to have them completed, and following up and making sure that that is what's happening. And a strategy that can be even more efficient is concurrent documentation. And so then your clinicians aren't finishing their day exhausted from seeing patients, from running groups, from having individual therapy sessions, and then have to spend another few hours writing their documentation, right? Concurrent documentation allows you to kind of wrap up the session, or to document during the session. So then, but this is not just a quality or documentation opportunity, it's a clinical opportunity, because you're engaging the person that you're seeing in their documentation, and it's your opportunity to summarize the session, summarize what their steps are between the next time they see you, if they have any homework, if they have a specific discharge plan or a new medication protocol. If this is your opportunity to do that with them. And then another option, if we're not quite at concurrent documentation yet, because that also takes clinical, a different type of clinical skill, is allowing for a certain time frame for documentation at the end of the session, so that all of that information, all of the information and all the different things that happened in the session are fresh in the person's head. Next slide, please. I keep going to click on the slides. All right, so now we're talking about really getting into that quality assurance and quality improvement plan and schedule. And so we say QA and we say QI because you need both. Quality assurance, that's just the basics, right? Quality improvement, that's how do we keep getting better at what we do, right? And so, but we do need both, because we need those checks to just make sure we're doing the basics, that we're getting our documentation in, that we're documenting as to we're supposed to. But then we get into quality improvement, where we start measuring how we're doing at what we're doing, right? So there are some examples. So when we think about our quality improvement plan, we think about, what do we want to measure? And if you don't have a quality improvement plan, we start small. We think about, okay, is there something that my current payer is judging me on, is measuring me on? Or is there something that we know we're going to manage care, and that we see on the dashboard, or that we know is a HEDIS measure? We can select one of those and begin the practice, start flexing our muscles at quality improvement. So deciding what it is. And if you don't have any of those requirements, just what do you want to know about how the people you serve are doing, right? So we are here as a federally qualified health center, and we're focusing on a population that's living with HIV. Are we seeing viral load suppression? Are people getting to undetectable? If we are running a mental health program, are people taking their medication? Are they engaged in their community? Are they feeling better? Are they able to work and engage with their family? If we're running a substance use disorder treatment program, are people engaging in less risky use? Are they, if they're on MAT, are they taking their medication? Have their children been returned to them? What do you want to measure that shows how you're doing what you're doing? And then that's why you want to measure it, right? Think about, we want to measure it because we want to know how we're doing, or we want to measure it because we want to make sure we're satisfying our stakeholders. That's like we talked about in that first slide, right? Is thinking about what your stakeholders want to see. And then you think about, how do you want to measure it, and how are you going to collect that information, and about whom do we want to measure it? Because there's lots of different things that we can measure quality. Are we measuring it on our current population? Are we measuring it on the community and the entire population we could be serving? And then where can we track that information? And that goes back to that fear we all have, right? That many people expressed about value-based payment, is tracking the data. And so thinking about, and that goes back to what I said when we first start thinking about quality improvement, is keeping it simple. When you want to start thinking about this, think about something you know you can track and you know you can get the data. So if you want to, like, let's say you want to track time to first appointment, and you don't have a sophisticated electronic record, think about, okay, well, we actually have a sheet where we track when that person called and then their first appointment. You know, you can gather that, start tracking that, right? And so thinking about where you can track the information, and then what steps, and then as you continue to track more things, you become more sophisticated with this. So an example is, the clinical director maintains a dashboard with key measures. So we look, and what we kind of put here, we put 3 different types of measures, and those are outcomes. Again, how are we doing at what we're doing? Process. Those are the measures that we measure because they're going to help us get to improved outcomes, we hope, if we're selecting the right ones. And then business operations, because you really also want to always, especially for value-based payment, be measuring how your business is doing, because that's how you're going to keep your doors open to be able to keep doing the awesome work that you're doing, right? So some of the outcome measures at this clinic, and they are a very comprehensive clinic. They look at improved mental health symptomology. They look at the number of toxicology screens showing reduced use. They're happy if use is reduced. Number of people living with HIV who are virally suppressed, and number of people with diabetes who improve their HbA1c. Okay, so those are some outcomes that they hope that their services achieve. So by coming and engaging in therapy, people are feeling better. Their PHQ-9 scores are improving. Their toxicology screens are showing reduced use. We're starting to do better. They're starting to feel better. They're starting to practice those skills that we're giving to them, that we're helping them to acquire. We're not giving them, they're using them. They're able to, because those things are doing better, they're able to adhere to their medication, and they're no longer detectable. And then because of that also, we're not drinking anymore. We're engaging in healthier eating and exercise habits, and we're able to adhere to our medication schedule. Our diabetes is improving. So those are all the different things that we're looking at that show that what we're doing is being effective. And then process is number of no-shows. That's important, right? Because if people don't come to us, we can't deliver our interventions, right? And then that shows us then we start to drill down with those process measures, and we start to say, why are we having this high no-show rate? How is our engagement? Are we trauma informed in our approach, or do people feel on guard when they come in? Do they feel judged? What are we doing that's making people no-show? Are there social determinants of health issues that are getting in the way of coming? Do we need to think about transportation? Do we need to think about appointment times? What do we need to do to improve no-show rates? And then percentage of people retained in care at 30, 60, 90 days. So they're measuring it. They want to make sure that that they're keeping people so they can begin to look at those outcomes. And then they're looking at percentage of revenue collected, because we have to look not just at what we bill, right? Like not just especially if we're moving from fee for service. We did our service. We wrote our note. We created a bill. It went out. Most of the time we got paid if the person's Medicaid was active and, there was nothing majorly wrong with the documentation. Now we have to look at we deliver the service. Did we document it according to what the payer wants to see? Was the claim clean and coded correctly? And if we didn't get paid, did we chase that denial? So we're looking at, we start to measure how much of that revenue is actually coming in, so that we can be more efficient in our operations. And then another business operations, often the percent of time spent in direct service, because once we start to get to value-based payment and thinking about getting people healthier, we want our people who provide direct service to be spending the majority of their time with the person, right? Who they're working to help improve their symptoms. So we want to make sure that we're not weighing them down with administrative burdens, that we're making documentation systems that are effective, that they're able to engage the people on their panel so that they do keep coming back. And so those are some of the different operations that we look at, because the percent of time spent doing the work you're there to do is going to lead to improved revenue generation.
Hey, Debbie, can I interject something?
Yes, please.
I love that last one, because we opened clinics on military bases in Afghanistan years ago, and I had learned the secret to good care from a couple of other really good physicians that taught me every patient should get enough time.
Yes.
That's the secret. I mean, that's hard to do at first, but woven into this process, if we do it right and we code it, we diagnose it right, we document it right, and we code it right, is money to do that. Every patient should get enough time. The other thing that you mentioned really fast in our medication assisted treatment program, we didn't have evening hours, and our highly successful patients didn't want to leave their jobs to come in. Mm-hmm. So we had to make a change in process, and we were really glad to do it, because these people, they're better. And mm-hmm. So I don't have a problem filling those slots in the evening, because it's with patients that are really doing well. So mm-hmm. Yeah, measuring how many of our patients really need evening hours is actually a sign of success.
100%. Absolutely. And that's what we're saying, right? Like, it's that shift, because we're not just thinking about every patient should get enough time. We're not just thinking about, I've got 15 minutes to deliver this service. Once we start to move away from this volume driven service, we start to think about, Debbie, she only really needs a shorter intervention. Like she can't maintain like sitting in a room with someone for a long period of time, and does better with 20 minutes. I don't have to try to keep her in her chair for 50. And but Todd needs he needs a longer time. It takes him a while to open up. We have to warm up, and then we have to kind of we have a lot to talk about, or so we are able to start really doing things according to what that person what is required to help that person better. All right, next slide, please. And this is your slide, Todd.
Yeah, I was going to point out something. One of the guys I learned every patient should get enough time. I went by his office. I saw his office lights on at 7 o'clock at night, and there were still people in the waiting room, and he was out there telling everybody, you know, I've had some more difficult patients today, but everybody's going to be seen and everybody's going to get enough time. And his patients loved him. Anyway, so the clinical documentation improvement. So you really need a team. I tried to say that earlier. It isn't just about the physician or practitioner anymore. It's about are people enrolled appropriately? Do we have their information? I really like sort of a pre-screen of charts so that when the practitioner goes to see the patient, if it's the first evaluation of the year, that the previous year's diagnosis should be right there in front of the doctor, because those things need to be addressed to see if they still have those things or not. You know, if there's been a consult that's come in or some laboratory or x-ray, it needs to be right there when the physician sees it. So can administrative people do those things? Yes, people that have worked in medical practices know what's important a lot. So to try to help take care of the people that cost the most are people that don't cost as much, but maybe should be paid better, because they're going to help the providers with throughput. It's a team effort. And when it's over, somebody should be looking at that chart and making sure that it's documented appropriately and it's going to pass, and then that it's coded correctly too. So Heritage Valley Health System, Pennsylvania, implemented a clinical documentation improvement program and saw a 27% mortality rate reduction. Wow. And a provider's office, the CDI staff will review the medical record and identify issues like medications prescribed, but the condition for which it is prescribed is not listed. I kind of mentioned that. So people can't just assume that we know what you're thinking because of the medication you prescribed. The cause and effect relationship between two conditions was not documented. Very important, especially in diabetes and other things. There's clinical evidence for a higher level of severity of a diagnosis than was reported. So yeah, that's sort of like saying heart failure when it was really more complex than that. Or it was unstable angina when we just called it chest pain. Again, remember that signs and symptoms don't hunt. That signs and symptoms are not a diagnosis, and we see that a lot. So it's all about the patient population, severity of illness and/or risk of mortality, patient safety indicators, hospital-acquired conditions. So somebody's got to be reading through the hospital discharge summary to see, are we aware of everything that they found in the hospital? That's actually a really important one when we're doing the outpatient work. And that also goes along with if we sent people off for consults. I can't tell you how many times people have been sent for consults and it's never been mentioned by the person that sent them out for a consult. I mean, my first chart I ever reviewed, I told the doctor, I looked at it, he goes, wow, this guy's sick. He's got all these illnesses. Oh, and he's got cirrhosis. And he goes, he doesn't have cirrhosis. And I said, it says so right here 2 years ago. And he went, well, I won't tell you what he said because he cussed. And he totally missed it. And so it's out there. I mean, we're all fallible, and in fee for service, you're fallible and so busy that you don't take the time to dig in. Key quality measures. We want quality. There are some measures that people are looking for, some of which we might not think about. So we need to learn what the quality measures are and follow them. Claim denial rates. Yeah, if we're getting a lot of denials, we need to dig in as to why and understand hierarchical condition categories. You will not learn it all. You will not memorize it. You're going to memorize some of, especially since there are so few things that risk adjust in mental health. You'll learn those. But on the other hand, and in medicine, you'll learn some of those, but you don't want to always use the same one. Like in diabetes, it can change based on what other complications they have. And diabetics have a lot of complications. So, and they also have to be diagnosed separately. Anyway, so a CDI, clinical documentation improvement, also includes a lot of education for practitioners. It should probably include, depending on how big a practice you have, education for coding staff. And by the way, a coder can assign a code if it's documented clearly. An auditor reads between the lines and goes back to the doctor and writes them a little love note that we call queries and says, what did you mean by this? Because you didn't do it all the way. So there's a lot of digging in to do, but it's a whole team approach. And people, the admin people in an office, after they've been there a year, or for a period of time, they know a lot about how this works. So let's use them even more. Let's pay them, to do it. But if you get somebody really good, you're going to start capturing more things. So next slide. So am I doing summary? You? Provider and facility compensation is tied to high quality documentation, coding, and quality metrics. So I think we kind of beat that into you today. Healthcare providers need to prove through clinical documentation and tracking outcomes and quality that you're delivering high quality care. When I worked walk-in clinics, I only found out about the ones that got worse, or sometimes they come back in and bring me cookies and say, you did a really good job. But did I really know? And the answer was no. Data tools are critical, especially those that allow real-time reporting to drill down to ICD-10 codes. Really, absolutely necessary. I hear that you're all going to electronic records. That does help. It's going to be difficult for a while, but once you get in there and you learn what reports you can generate, you can start seeing how it's working or not. Training and continuous quality improvement are essential. And it's important that all chronic conditions are documented thoroughly and to their greatest specificity for quality patient care, defensible documentation, and for the greatest reimbursement potential. It's all about specificity. So as far as I'm concerned, you don't have to write a book on everything, but you need to be specific, and you need to write something about management, monitoring, evaluation, assessment, and/or treatment. The accuracy of physician documentation and effective revenue cycle management allows organizations to adopt proactive initiatives such as clinical documentation improvement and training that maximizes resource and achieves optimal outcomes. What does that mean? Well, it's that example of before the practitioner sees the chart. That's one example, is have somebody go through the chart and make sure that there are some notes, some little love notes to the practitioner about what's missing, what needs to be addressed. And then they won't get missed. And then the more things will get picked up, and there'll be higher quality care, and there'll be more reimbursement. So I love the fact that this reimbursement process really supports a higher level of care. And I can't say that enough. Next slide, please. That's what I thought. If you still have your appendix, no, I'm just teasing.
I do not.
Question. So I wanted to know if I answered the question about the MCOs do not choose the reimbursement rate for each diagnosis. That is chosen that's already chosen, and it changes, like I said, a little bit every year. There's a question up there is, how does that revenue equalize between similar providers for the same metric? And it really doesn't. While they equalize it for each of the conditions. So every provider is going to basically for their group of patients get the same revenue for the same risk scores. That makes sense. Any other questions?
We did have one. I have one. I want to know if we if we helped with the fears you have about value-based payment, or if we scared you more. But we did actually receive a great question in the chat, which is, are there DC regulations or federal regulations that we can reference regarding the different elements, components, providers should be captured in a session or clinical note? Debbie mentioned what notes should contain, but what gives MCOs the authority to enforce those components, elements in a session note? I'm happy to explain my question more if needed. Yes, we'd love for you to come off of mute if you feel comfortable and hear a little bit more. But it was a great question, but if you want to explain a little bit more, that's great.
Hi, can you hear
So
me?
did you?
Yes,
Did you,
yes, can hear you.
go ahead. Yvonne, we saw your name. Go ahead.
Can you still hear me? I'm
Now
sorry.
we can, yes.
Okay. So Debbie provided great examples and explanations of what should be captured in session clinical notes earlier in the presentation. One of the things we struggle with is that we haven't been able to find federal regulations or DC regulations requiring those different elements, if you will, in session notes. So containing that level of detail, like in home health, for instance, it's more heavily regulated right now than for behavioral health. And so my question is there like specific regulations that you guys know of, maybe that we don't know of, or that we could reference when we are asking providers to contain a certain level of details within their session notes?
That's an excellent question. For home health, I'm not sure if there is a specific template that's out there, and I'm less familiar. And so Todd, also please jump in. I'm less familiar with that, but I mean, I think as far as enforcing with providers is really looking at what's required for you to get paid and for you to feel comfortable that services are being delivered correctly. And then as to define and to defend the codes that you're using. And then write that into your policies and procedures that then is enforced with the providers as part of being a part of your network or home health agency. Does that make sense?
Yeah, my question was actually because the home health, it's more heavily regulated. There's more requirements around those different expectations. But for behavioral health, it seems like that regulations haven't caught up to speed yet, if you will, from our research. And so when having these discussions with providers, we always like to go to their regs and be like, okay, per reg, XYZ, you're required to do, XYZ that helps us be able to enforce it, or set that level of expectation from providers. But we haven't been able to find that for behavioral health. And I think the examples and everything you went through earlier was great. I mean, that is exactly the type of details we would like in those provider session notes when they're provided to us. But now my question is, where can we go to point and say, this is what is requiring you to contain this level of detail, and that is why we are expecting this from you anytime you provide us with session or clinical notes.
Okay, perfect. Thank you.
Help us give that ability to enforce.
Yes, no, absolutely. Thank you. I was thinking you were asking about it for home health. So that note we used is a format that a lot of Department of Behavioral Health providers use, I believe is issued by the Department of Behavioral Health for their providers. And so all of those regulations are should be posted with the department, with DC, DBH. And so to be able to find what's required to be in a session note.
And if I could add in, there's another reason to do the documentation, because we are tying documentation to money, but we're also tying documentation, good documentation, to quality.
Yep.
And when I ran ERs, I was learning so much by reviewing my other ER docs, their documentation, what was good, what was bad. And I was the only one learning it. So at the beginning of every shift, they'd come in and they'd have 2 or 3 charts to review from the guy or gal before them. And have each of your providers look at the other providers and be nice, but can they tell what's going on with the patient? And and then they get reviewed also. I really like that, because we do learn by example. You know, my wife has taught me after 40 years of what I need to be doing, and a little over and over and over again. But docs do learn, and it's funny. I have one of my docs who just the other day said, "I've read so many charts now. I really did not document well, and I've changed my documentation now." You know, so it's not just about the regulation. It's also about, can you tell what's going on with this darn patient based on what Dr. Jones wrote? Or can Dr. Jones tell what you did with your patient based on what you wrote? You know, and it's kind of interesting. So.
And this is Caitlin. I'm just going to chime in. I'll put it in chat without getting really specific. Your best sources, Debbie noted, is Department of Behavioral Health. Yvonne, I think it was your question. And there are different regulation behavioral health side. So what we can do as a starting point is link those rules, put them in chat. But I would encourage you to reach out and to review those. It is going to depend on the level of service. So I don't think we're prepared to answer the specifics about each and every level of service, but we can put those rules in chat that link directly to those standards for, you know, MHRS, for instance, for the different level of care that your organization may be interested in providing. I hope that's helpful.
And as far as the clinical diagnoses and what needs to be there, it's interesting. Coding Clinic, which is Medicare, Medicaid Services, CMS, and the American Hospital Association, and AHIMA, American Health Information Management Association, produces every quarter. They answer questions about coding. They have. And every now and then they do complete initiatives about coding and how it works. They've been releasing those quarterly coding clinics, is what they're called, for 44 years. There's a lot of them. So it helps to have somebody who knows most of that. I have people that work at Marcy that actually know almost all of those. At least what some of them have negated themselves over the years. And when you're training, if you're a busy enough place that you're going to have your own coder auditor, have them look at training. AHIMA offers training, and also some backup support. And so do we.
Any other
For the
questions?
other questions,
And
we
feel
still have
free to-
some more time for Q&A.
Feel free to just drop it in the chat or come off of mute.
So while we're thinking about other questions, so my reflections, and I said it earlier, but I really mean it, is about 15 years ago when they started with Medicare Advantage and made it a risk-adjusted reimbursement model, it was like 7% of Medicare patients. It's now over 50%. They are dead set that 100% of Medicare is going to be risk adjusted by 2030. Medicaid has been slower. It's not in risk adjusted reimbursement is not in every state yet. But it's getting bigger and bigger. But if history repeats itself, and it will, what's happened in Medicare Advantage, which really started 15 years ago, is that they tightened it up and tightened it up, and they're doing more and more audits. They're looking for people doing it right, and they're looking for people doing it wrong. And although, you know, you're going to be brand new at this and the rules are not quite as heavy, you might as well start practicing, because it's a really good model for everybody. It's a good model for the payers. It's a good model for the government. Commercial carriers are way into this, and you know that commercial carriers don't get into stuff unless they're going to make some money. Oh, and then the physicians that work and see their patients, it's actually a good deal for them too. So, and the physician groups. So this thing's, as I said, the light at the end of the tunnel is a freight train, except it's actually going in our direction. We're getting hitch a ride on it, and we need to go forward. There's a lot to learn, but a little baby steps. Let's just get started on the documentation pieces and the coding pieces, and just good documentation.
Hi, this is Yvonne again. Just one other question. Is there a session or clinical note template that you would say is a good source to provide to behavioral health providers?
Yvonne, are you all going to be using an electronic record? Yvonne, you're muted. There you are.
So there's some, are you talking about in the way that the providers provide us with their notes, or their methods for documenting their session notes?
Their method. So I don't know the different systems that are out there for behavioral health. I do know the ones for medical really well. And I believe that some of the electronic records would help the administrative side keep track of everybody and what's been done, but also has that space for clinical documentation of notes. And I kind of wonder if you look at that and see, so how do they parse that out? I've not seen it, and I can go, now that you have my curiosity, I'm going to go look it up.
Any other questions in the meantime? Feel free to come off mute, drop in the chat.
By the way, I'm not going to be able to look that up right at this moment, but I will look it up and we can get back with Yvonne Smith. Okay.
Thank you.
All right, so I guess next up is, thanks for joining today's session. So if everyone could please complete the online evaluation, I am dropping it in the link, or sorry, in the chat now. Your feedback is important to us, and it helps us improve technical assistance offerings. We appreciate you taking the time to complete this survey. The most important note about the survey is that it is required to complete it if you are requesting continuing education credits. So I've just dropped it in the chat. And also later today, everyone will receive an email with the link, just so you have it again. So all the learning collaborative sessions, the recordings and the slide decks will be available on the Medicaid Business Transformation DC webpage in the next few days. Visit the website for additional initiative information and value-based payment resources, including previous webinar recordings and tools. And I will drop a link to the website again.
So can I jump back in? I
Yeah.
did look a little bit for behavioral health electronic records. And actually, there's quite a few of them and designed for behavioral health. So if I were you, I'd get a demo and see what are they doing? It seems like there are quite a few of them. Get some demos and
So,
see.
and I want to chime in here, Todd, because there are some district specific requirements that are actually that EHRs in the district have to be ONC certified. And there's
Okay.
a process underway in which the district is working with providers and through DCPCA to help providers determine which ones are meet that requirement. So if you folks aren't connected with that work, I would encourage you to do so. But those standards, it's my understanding, are going to go live. The requirements that the EHRs be ONC certified October 1 of this year. We can follow up if it's helpful if folks don't have information about that. This is specific to behavioral health. I want to be clear, but we can attach that in a follow-up email. But I do see some of providers familiar with these requirements. Let me know.
Great, thank you, Caitlin. So I guess just my last little snippet. So if you haven't done so already, sign up for the Integrated Care DC newsletter to stay up to date on the district's initiatives, resources, and technical assistance opportunities. And here is a link to sign up for the newsletter. And I guess not last but not least, here's contact information for today's presenters are listed here. Please feel free to reach out to the presenters if you have any additional questions after the session. I guess, Yvonne, we have your email from from when you registered, so Todd will follow up with you directly. So does anyone else have any other questions? We do have some extra time, or we can end a few minutes early. I guess if not, that concludes today's session. Thank you guys again for participating in the Medicaid Business Transformation DC Value-Based Payment Learning Collaborative. And again, the most important thing about what my little spiel was, please complete the evaluation if you have not done so already, especially if you are requesting CE or CME credits. That is the most important. Thank you so much.
Measure.
And quality measure. Thank you. Thank you so much, everyone. Have a great day.
Thank you all.
Thanks.